What's going on, guys, and welcome back to the podcast. Today, we are taking a look at patellofemoral pain syndrome. I'm your host, Dr. H, and today on the World's Okayest Physical Therapist podcast, we're going to be delving with a request. So, like I said, it's the patellofemoral pain syndrome. Here, let me go ahead, start the slideshow for you. For those of you that are watching, you'll be able to see the slideshow. For those that you're not watching, you can find this on YouTube and Rumble. So let's get started. What is patellofemoral pain syndrome? Well, it is a broad term that is used to describe pain around or behind the kneecap, usually brought on or worsened by a whole host of activities, such as squatting, running, going up and downstairs, particularly more going downstairs is what I've seen, sitting for long periods of times. So one of the things that usually you'll see is somebody will say, hey, I had to sit because I was driving and had to have my knee kind of slightly bent at this kind of awkward angle for quite a while I was pushing the gas pedal or not. And after that, it was really, really achy. And you can see here that I've added a couple of things to the image. If you can't see it, let me describe it to you. I have a picture of the knee joint with the femur on top, the patella in the middle, and then the tibia below that. I have kind of outlined this this knee joint. The tendon that attaches to the patella and runs up towards the femur and attaches to the quad is, of course, the quad tendon, and the tendon that attaches to the patella and runs down to the tibia would be, of course, the patellar tendon. Now, the purple box would represent what is the quad tendon, while the orange box here would represent what is the patellar tendon. And these play a role in the mechanics of the knee joint. And a lot of times, when someone comes in with patellofemoral pain syndrome, they're having that pain in either one tendon or both, or possibly even the knee joint, because that's what the name patellofemoral pain syndrome means. It means you're having pain in either the femur or the patella, generally speaking. Unlike ligament tears or meniscus injuries, the patellofemoral pain syndrome doesn't usually involve structural damage, and it's usually not depicted on imaging as anything more than maybe some edema, some swelling. Instead, it's really a lot more about musculoskeletal tightness and weakness, and some range of motion restrictions, usually due to tightness or maybe some stuff going on in the actual knee joint that result in pain that keeps the knee joint from operating optimally. So you can imagine if your quad is really, really tight and pulling that patella up towards itself, you're going to have some increased pain and some possible discomfort down the patellar tendon, which is having to be put under constant tension this whole time. Vice versa, if you have a kneecap that's not moving really well, let's say the patellar tendon is let's just say super stiff, and the quad tendon is getting an extra big pull on it, that could of course lead to some discomfort in there. So kind of a tricky one. There's not really one use alone. A lot of people say it's an overuse injury. They'll usually say, hey, I'm a runner, I do this too much. But 9 times out of 10, you're looking at some sort of myofascial tightness, like in the hip flexors, in the quads, for example, or in the hip flexor or in the hamstrings, somewhere around there that's causing some of that pain at the knee joint, because that whole leg is just not operating the way that it should to give the knee a little bit of a break. One of my favorite sayings is that the knee lives in between the hip and the ankles and it has nowhere to hide. So any weakness of the hip or the ankles is usually going to manifest at the knee at some point. And sometimes that's just the case. Causes. It's a multifactorial condition. There's usually, like I said, not one reason, one main contributing factor. Usually it's a whole bunch. Like I said, the overuse is one that people say quite a bit, that they suddenly increase their mileage while running, and that caused an increase in pain. Or if you have like a CrossFitter and they're doing repetitive squatting or jumping and they're not giving themselves plenty of recovery, that's one as well. The poor biomechanics, that's the fancy way of saying what I said already. Weak muscles, tight hip muscles, tight hamstrings, and etc. That all just change the mechanics around that knee joint. One of the chief muscles for sure that is weak, that can cause a lot of knee pain, is the glute med. That is your hip abductor. It lives in the outside of your hip. It's responsible for kicking your leg to the side, balancing you when you're in single leg stance, things like that. Very important muscle, very important for knee health, and a lot of the times criminally overlooked and undertrained, and it results in knee pain. This is especially true in runners. Runners are, in my experience, notorious for not training these muscles, and it ends up with a lot more force going through their knees than is necessary and can cause a lot of knee pain and overuse of other muscles. Historically, too, there used to be a very big trend in physical therapy that believed the vastus medialis oblique was responsible for like a lot of knee pain. That's kind of fallen to the wayside more recently. They used to be all about trying to train one specific part of your quad instead of your whole quad. That would be your vastus medialis oblique, would be that one part of the quad they really, really wanted to focus on training. Now the approach is kind of strengthen the quads, make sure it's stretched, and you got proper patellar mobility, and your pain should start to get better as your hips get stronger and everything else gets stronger and has its appropriate range of motion. Along with the poor biomechanics, like I said, is poor patellar mobility, meaning your kneecap just isn't moving the way that it's supposed to. And a lot of people I see, at least in the clinic, that one of the things that gets them better pretty darn quick is moving their patella and what's called patellar mobilizations, which is literally just it's a person going in there and moving the patella, usually in a superior and inferior, that means up and down direction, to just kind of get it loose and get it moving. Because a lot of times when someone comes in with patellofemoral pain, that kneecap just does not want to move. Tight structures, like I said, here, when I was searching through the internet, one of the things they said was the tight IT band or lateral retinaculum. Typically, it's quad tightness that I've personally seen, but any sort of tightness, if you go into, if you're evaluated by a medical professional, if you have any sort of musculoskeletal tightness, they're probably going to go after that with some sort of stretches or something, right? You're not going to get away from being like, oh, you have the world's tightest hamstrings. Let's not stretch that. No, they're going to go in there and they're going to stretch that. So any musculoskeletal tightness anywhere from the hip or the knee is definitely something that would probably be addressed and could be causing this issue. And foot mechanics, yes, of course. Like I said, if the ankle is having a hard time with its strength or range of motion, or it's having bad mechanics, a lot of times that's going to refer straight up and into the knee. And it's going to be just a matter of time till it's there. So that's one of the things where it could be an overuse or overcompensation / poor biomechanic issue going on, right? So how do you treat it, right? How is the way it's usually treated? The good news is that patellofemoral pain syndrome responds very well to physical therapy. And usually for moderate cases, you're looking at 6 to 12 weeks. For more severe cases, you could be looking at months, like, anywhere beyond 3 months. Activity modification is number one. It's the biggest thing that you can do, which is what is now being called in physical therapy active rest, which just means don't do things that cause pain. It's reducing your running volume, reducing your lifting volume, scaling back your motion, your range of motion if you're doing a squat, to make it pain less, things like that. Substitute any low impact options, or sorry, substitute with low impact options like swimming or cycling or rowing instead of running, jump roping and things like that. Things basically that are higher forces going through that knee, that quad tendon, that patellar tendon, trying to supplement those with still cardiovascular, for example, in this case, cardiovascular exercises that you can perform that still get your heart rate up and can keep you fit, but don't cause that extra impact in the knee joint. If you watch the previous episode 13 on the podcast, you would know what I'm talking about. There's those 35 exercises that were ranked for the knee in terms of how much force it's putting through the knee joint, the patellar tendon, the quad tendon. Strengthening, absolutely. Go ahead and keep strengthening everything would kind of be the approach there, right? Go in, if you find hip weakness, strengthen it. You find quad weakness, strengthen it. Hips, or hamstring weakness, strengthen it. Ankle weakness, strengthen it. If it's weak, strengthen it and build it back up. A whole bunch of exercises listed here, right? Clamshells, that's for your hip abductor. Monster walks, again, hip abductor. Side lying leg raises, hip abductor. Hip thrusts, glutes, hip extensors. Quad training. One of the things as well is you want to make sure your glute max is strong. You want to make sure your glute med is strong. You want to make sure your quads and hamstrings are strong and your ankles are strong. And then you probably want to take a look at the hip flexors as well. That's one thing that a lot of people don't look at is a lot of times people have weak hip flexors, specifically runners. And that can upset their mechanics when they're trying to run. And of course, like I said, if the hip is weak, it's going to probably refer down to the knee. So just basically anything and anywhere. Stretch and mobility work, 1,000%. It's the first thing I think of when I think of patellofemoral pain syndrome is I got to make sure that patella is moving. I got to make sure that any muscular tightness you have anywhere, you're stretching. I personally like to hold my stretches for 1 minute at a time, at least 3 times. That's my favorite dosage. And there are definitely times where I'm holding those stretches for a little bit more than a minute. And there's definitely times where I'm doing 5 or 6 stretches a day for 1 minute instead of 3. Taping or bracing is something I don't really personally see a lot of, and I don't do, but I know it's an option. So I really can't speak too intelligently on that, but I know it is something that people do. Personally, I just think taping, while it can help with what we call patellar tracking, which is moving the patella in the way that it should. A lot of times I think taping is actually more about proprioception and helping provide a sense of stability instead of providing actual structural stability. But there are definitely sage physical therapists out there and much wiser people than me that would absolutely come and take issue with me saying that and saying that the tape actually does more than proprioception, which is just knowing where your body is in time and space and providing a sense of stability. They would come and they probably beat the boots off me for saying that, but that is just been my experience. So if you're one of those well-seasoned, saged physical therapists or physios out there and you want to come teach a young pup what's what and why he's wrong, please feel free to do so in the comments. But again, my experience has been that taping doesn't actually do that much besides make you feel a bit better and feel a little bit more stable. And honestly, my approach is if a person asked me to do it, if a patient asked me to do it, I would do it. I wouldn't say no. I'd be like, sure, let's do it. I mean, anything to make you feel better to get you back to doing what you want to do. I am very much a let's throw the whole kitchen sink at this problem sort of person if that's what it takes to get someone better. Foot orthotics, yep. Just like I said, if the issue's coming from the ankle and it's structural and it's not going to be solved by strengthening or stretching, yeah, orthotics is probably not a bad idea. And of course, gradual return to sport, which is the one that everybody misses with ankle injuries and knee injuries. Everybody wants to get back to doing exactly what they want to do as fast as humanly possible, and that leads to a higher rate of re-injury. So yeah, jumping, running, and cutting should be pain-free and controlled and be done in the clinic before returning to the track, the field, etc. So I listed here some of my favorite exercises. These are the ones that I use for myself when I have knee pain, and these are the ones that I've seen work for quite a few people. Now, I'm not saying that this is what you should do if you have knee pain. You should consult with a medical professional if you're having knee pain. But this has been how, for example, I have seen things done that have resulted in people getting better. But this is individualized and personalized for them. This is not for everybody. So you can see I like to start with laying on your back, straight leg raises with no weight for 3 sets of 15. Again, this is for me. So that kind of gets my quad firing, gets my knee moving a little bit. Oh, sorry. All this is predicated on the fact that I've gone in and I've done hip stretches and I've done quad stretches out the wazoo. Whatever I found that was tight, I've stretched. That's what this is predicated on. I also do patellar mobilizations on myself. So I'll be sitting, turn my quad off, basically sitting there, take my hand cupped over top of my knee and I'm wiggling it up and down, assessing to see if it's tight. And if it is, I'm trying to work on that tightness. So then after that, I like to do my straight leg raise laying on my back, 3 sets of 15 with no weight. because if it's a little bit painful, usually for myself, I like to stick to the 3 out of 10 pain range or less. If it's about that and I can do a straight leg raise, 3 sets of 15 without that pain increasing, I'm going to hang around there. Then I'm going to go over to the quad machine. I'm going to sit down and do a seated knee extension. I like to do those again with no weight and a single leg kick out with a hold for 3 sets of 30 seconds. And from that point on, if I can do that and that's not painful, I'm going to add a 5. I'm going to try it again, and so on and so forth. And I'm going to try and see how much I can tolerate that 3 out of 10 pain or less personally to try and get that knee pain to improve. Then I'm going to do some wall sits. That's going to be where, you go and you find a wall and you sit. So I don't start at 90 degrees when I'm having knee pain. I might start at like 60 degrees, work my way down to about 45 degrees. Or sorry, I might start at like 45 degrees and work my way down to 60 degrees, trying to like see where my knee is at. And I'm going to hold there. Once I find some discomfort, but not pain, I personally like to sit there for 3 sets of 30 seconds, trying to build my way up to 3 sets of 45 seconds. After that, again, based on the study that we talked about in episode 13, I'm going to go and start doing some Bulgarian split squats. And I'm going to start at a half squat, work my way down to a full squat. I'm going to do 3 sets of 15 on each leg. And if those are pretty tolerable, one of the ways I modify it for myself is I add a 3-second pause at the bottom of the motion to really put some extra tension going through that tendon, make my quads work a little bit harder and sub-maximally load that joint and get that quad tendon, that patellar tendon, some extra love, give them a little bit of extra tension to improve them. And then I'm going to do some eccentric step downs. What that means is I'm going to, in a 1-second count, I'm going to step up. And then in a 3 count, a 1, 2, 3, I'm going to slowly step down off of that stair. As we know from, again, episode 13, we know that step downs are much more demanding than step ups. So I'm putting quite a bit more force through my knee. So what height would I start at? A full step? Absolutely not. I'm going to start on a 1-inch raise. I'm going to find something that's 1 inch tall. I'm going to do little baby step downs from there. And if that's painless, I might step up to 1.5 to 2 inches to 3 inches, so on and so forth, until I can tolerate a normal stair. I like to dose these for myself for 3 sets of 20 reps. Once I master all of that, and this is contingent on my pain level and my fatigue, but once I've mastered those exercises, I can progress to the next ones, which would be terminal knee extensions. That's me sitting there and kicking my legs straight with a band behind it while standing on it. Or just, I guess it's really better described as me straightening my leg. Again, you can check this out on YouTube. I like to do tempo knee extension holds. What that means is I like to kick up in 1 second, hold for 1 second, and slowly let it come down for 3 seconds, right? And again, I'm starting with no weight and a single leg kick out. This is me sitting on the knee extension machine, and I do that for 3 sets of 15, and I add weight to what I can tolerate. A single leg wall slide is just like a normal wall slide, except now it's a single leg. And again, I'm going to start at like a half squat, work my way down to a full squat, doing 3 30-second to 45-second holds, whatever I can tolerate. Then down into reverse lunges, because we know that reverse lunges are more demanding on the knee joint. Then Bulgarians, and again, I'm going to do that half lunge to full lunge, range of motion, whatever's comfortable, with the 3 sets of 15 reps. And then once I get really good at those, I'm going to add that 3-second pause at the bottom of the motion to really challenge my quad tendon and my patellar tendon. All of this, again, predicated on having 3 out of 10 pain or less, just because I know that tendon's going to be aggravated, and it's wanting to be submaximally loaded. And the more that I do these exercises, the better it should feel. The last thing that I'm going to do that is kind of the piece de resistance, it's the most highest level exercise that once I know I can do this without pain, I'm probably on the mend, I'm probably doing pretty darn well, is a single leg pistol squat with the TRX straps or some sort of strap, some sort of support. And once I can do 3 sets of 10 to 15 single leg pistol squats with no pain, I know I'm pretty much back to where I was before, because that's just my personal metric of what I do. If I can do 3 sets of 10 pistol squats on each leg with no knee discomfort and no knee pain, I know that I'm back to the level that I needed to be at personally. That's, again, my metric. If you guys saw the video earlier today that I posted on YouTube, you saw me doing these, and you saw that I think I made it to 8 before I had any instability. So I'm still working on my left leg anyway at getting back to being able to do this. So this has been my episode on the patellofemoral pain syndrome with some of my favorite exercises that I use to address it when I have it. We've also covered the causes, some likely causes of it, some anatomy. So hopefully you have a better idea of patellofemoral pain syndrome, and how to kind of catch it and understand what could be at play. In terms of this, it's something that usually you're going to go in and you're going to see your doctor. Your doctor is going to say patellofemoral pain syndrome. Then you're going to go to your physical therapist. Your physical therapist is going to do a bunch of assessments and come back and say, hey, I think it's actually this. It's quad tendinopathy. It's patellar tendinopathy. It's quad tendinopathy. All this stuff. Just don't be shocked if you hear that, because patellofemoral pain syndrome just means, again, pain around the kneecap. It's a very general statement. And when you go and see your specialist, like a physical therapist, they're going to delve in and say, actually, here's what's going on, and here's how we're going to address that. But it's typically going to follow the exact same outline that I gave you guys here. So this has been the world's okayest physical therapist podcast talking about patellofemoral pain syndrome. Please don't forget to like, comment, subscribe, share this with everyone you know, so that we can all be more educated about our bodies, about the Byzantine labyrinthine system that we call the American healthcare system. And while you're at it, please consider checking out the Patreon, the Teespring, which is where all the t-shirts and the stickers are at. Got an amazing bunch of t-shirts coming out. Keep an eye out for the app if that ever happens. We've submitted it 10 times, but we're getting there. And I think that's it. So everybody stay healthy, stay fit, and stay awesome. And I will catch you all in the next episode. Thank you so much for watching.